Welcome to the Dr. Izzy's Medical Podcast channel.
Hyperphosphatemia. Hyperphosphatemia is an electrolyte disorder in which there is an elevated level of phosphate in the blood. Most people have no symptoms while others develop calcium deposits in the soft tissue. Often there is also low calcium levels which can result in muscle spasms. Causes include kidney failure, pseudohypoparathyroidism, hypoparathyroidism, diabetic ketoacidosis, tumor lysis syndrome, and rhabdomyolysis. Diagnosis is generally based on a blood phosphate levels of greater than 4.5 mg per deciliter. When levels are greater than 14 mg per deciliter, it is deemed severe. Levels may appear falsely elevated with high blood lipid levels, high blood protein levels, or high blood bilirubin levels. Treatment may include eating a phosphate-low diet and antacids, like calcium carbonate, that bind phosphate. Occasionally intravenous normal saline or dialysis may be used. How commonly it occurs is unclear. Signs and symptoms. Signs and symptoms include ectopic calcification, secondary hyperparathyroidism, and renal osteodystrophy. Abnormalities in phosphate metabolism such as hyperphosphatemia are included in the definition of the new chronic kidney disease mineral and bone disorder. Hypoparathyroidism. In this situation, there are low levels of parathyroid hormone. Parathyroid hormone normally inhibits reabsorption of phosphate by the kidney. Therefore, without enough parathyroid hormone, there is more reabsorption of the phosphate, leading to a high phosphate level in the blood. Chronic kidney failure. When the kidneys are not working well, there will be increased phosphate retention. Drugs. Hyperphosphatemia can also be caused by taking oral sodium phosphate solutions prescribed for bowel preparation for colonoscopy in children. Diagnosis. The diagnosis of hyperphosphatemia is made through measuring the concentration of phosphate in the blood. A phosphate concentration greater than 4.5 mg per deciliter is indicative of hyperphosphatemia, though further tests may be needed to identify the underlying cause of the elevated phosphate levels. It is considered severe when levels are greater than 5 mg per deciliter. Phosphates in blood exist in a chemical equilibrium of hydrogen phosphate and dihydrogen phosphate, which have different masses. Phosphate and phosphoric acid are not present in significant amounts. Thus millimoles per liter are often used to denote the phosphate concentration. If milligrams per deciliter is used, it often denotes the mass of phosphorus bound to phosphates, but not the mass of some individual phosphate. Treatment. High phosphate levels can be avoided with phosphate binders and dietary restriction of phosphate. If the kidneys are operating normally, a saline diuresis can be induced to renally eliminate the excess phosphate. In extreme cases, the blood can be filtered in a process called hemodialysis, removing the excess phosphate. Phosphate-binding medications include sevelamer, lanthanum carbonate, calcium carbonate, and calcium acetate. Previously, aluminum hydroxide was the medication of choice, but its use has been largely abandoned due to the increased risk of aluminum toxicity. Hypophosphatemia. Hypophosphatemia is an electrolyte disorder in which there is a low level of phosphate in the blood. Symptoms may include weakness, trouble breathing, and loss of appetite. Complications may include seizures, coma, rhabdomyolysis, or softening of the bones. Causes include alcohol use disorder, refeeding in those with malnutrition, diabetic ketoacidosis, burns, hyperventilation, and certain medications. It may also occur in the setting of hyperparathyroidism, hypothyroidism, and Cushing syndrome. It is diagnosed based on a blood phosphate concentration of less than 2.5 mg per deciliter. When levels are below 1.0 mg per deciliter, it is deemed to be severe. Treatment depends on the underlying cause. Phosphate may be given by mouth or by injection into a vein. Hypophosphatemia occurs in about 2% of people within hospital and 70% of people in the intensive care unit. Signs and symptoms. Muscle dysfunction and weakness. This occurs in major muscles, but also may manifest as diplopia, low cardiac output, dysphagia, and respiratory depression due to respiratory muscle weakness. Mental status changes. This may range from irritability to gross confusion, delirium, and coma. White blood cell dysfunction, causing worsening of infections. Instability of cell membranes due to low adenosine triphosphate levels. This may cause rhabdomyolysis with increased serum levels of creatine phosphokinase, and also hemolytic anemia. Increased affinity for oxygen in the blood caused by decreased production of 2,3-bisphosphoglyceric acid. Causes of hypophosphatemia. Refeeding syndrome, respiratory alkalosis, alcohol use disorder, malabsorption. Other rarer causes include certain blood cancers such as lymphoma or leukemia, Hereditary causes: liver failure, tumor-induced osteomalacia. Diagnosis: hypophosphatemia is diagnosed by measuring the concentration of phosphate in the blood. Concentrations of phosphate less than 2.5 mg per deciliter are considered diagnostic of hypophosphatemia, though additional tests may be needed to identify the underlying cause of the disorder. Treatment: standard intravenous preparations of potassium phosphate are available and are routinely used in malnourished people and people who consume excessive amounts of alcohol. Supplementation by mouth is also useful where no intravenous treatment are available. Historically, one of the first demonstrations of this was in people in concentration camp who died soon after being refed. It was observed that those given milk had a higher survival rate than those who did not get milk. Monitoring parameters during correction with intravenous phosphate. Phosphorus levels should be monitored after 2 to 4 hours after each dose. Also monitor serum potassium, calcium and magnesium. Cardiac monitoring is also advised.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.